Welcome, everyone. I'm Nellie Gontier, Education and Training Specialist at Parkinson Canada. Thank you for joining us today for our webinar on atypical Parkinsonisms, PSP, MSA, and CBS, signs, symptoms, and treatment. Our expert today, Dr. Connie Maris, will be taking us on a journey through the distinctions between these three neurodegenerative disorders that are often confused with Parkinson's disease. Dramatic differences in prognoses and additional symptoms, a review of the current understanding of the causes of these rare disorders, and the treatment therapies will also be discussed. Dr. Maris trained in neurology and movement disorders at the University of Toronto, where, subsequently, she obtained a PhD in epidemiology. She also went on to train in epidemiologic research methods at the Parkinson's Institute in California. She's currently an associate professor of neurology at the University of Toronto and a neurologist at the Toronto Western Hospital's Movement Disorders Centre. She serves as an associate editor for the Movement Disorders Society and sits as vice chair of the Research Ethics Board at the University Health Network here in Toronto. Her areas of research focus include the epidemiology and clinical expression of Parkinson's disease and evaluating clinical assessment tools in Parkinson's disease. I would also like to take this opportunity to thank our sponsor, Synovian, for making this webinar session possible through an unrestricted educational grant. Before we begin, I'd like to take this opportunity to inform everyone that today's session is being recorded for future viewing and can be accessed by visiting our website at www.parkinson.ca and by visiting our YouTube channel, The Knowledge Network. To report any technical issues at any time during the webinar, please go to the menu at the right of your screen. To open and close this menu, click on the red tab. Use the To Admin button at the bottom of the menu. Clicking this will bring up a pop-up menu. Select Ask a Question, then type in and submit your request. Every effort will be made to answer all webinar-related questions at the end of the presentation. We ask that questions are of a general nature and do not seek medical advice. And with that, please join me in welcoming our guest, Dr. Maris.
Thank you, Nellie, and thank you everybody for joining today. It's a pleasure to speak with you all about this important topic. I'll be covering in the presentation today specifically a review of what Parkinsonism is and how PSP and MSA, or progressive supranuclear palsy and multiple system atrophy, relate to the term Parkinsonism, as this is a fundamental term that many of you may have heard in your reading and from the doctor over the course of the illness. I'll review signs and symptoms of these two conditions, talk about our current approach to treatment of the conditions and their specific signs and symptoms, and then I will touch on new research progress at the end. So what is Parkinsonism? Parkinsonism is a term that's often applied to PSP and MSA. They're both examples of disorders that cause Parkinsonism, and often this is a quote, diagnostic term that is applied early in the condition. Parkinsonism is actually not a diagnosis per se, but it's a description of a syndrome of abnormal movement that's characterized by tremor at rest, rigidity or stiffness, bradykinesia or slowness, and postural instability or a loss of balance. And Parkinsonism is a term applied when a person has a combination of several of these, but doesn't have to have all of them in order to be classified as having Parkinsonism. You can see in the pie chart on the right-hand side that the majority of cases of Parkinsonism are due to Parkinson's disease, and PSP and MSA constitute a smaller minority of cases of Parkinsonism. And there are other causes as well, such as medications and strokes that can cause Parkinsonism. So it really is a very non-specific term and often is used as a placeholder diagnosis until there are other features that emerge with the progression of the condition which clarify the actual diagnosis. Next, I'm going to show you just some very brief videos which show you what the cardinal symptoms of Parkinsonism look like, just so that we all know what we're talking about. The first video will show you a picture of a typical rest tremor, typical of Parkinson's disease, but also seen in multiple system atrophy and PSP, although not in all patients with these conditions. You'll see that the gentleman has a tremor at rest when his hands are doing nothing in his lap, and this tremor becomes less severe with action. And this is typical of the tremors of Parkinsonism, which is why it's called a resting tremor.
Okay, now go ahead and stretch your hands, both of them. Okay, put them right under your nose. Okay, now with the right hand, tap like that. Now do the same with the left.
And the next video.
I want you to open and close your fist fully as you can and quickly, as big and as quick as you can. And now the other side. Okay, and with your right hand touch each finger in turn like that. As big and as quick as you can. And now pretend you're screwing a light bulb like that.
That second video was an example of slowness of movement or bradykinesia, which you saw in the gentleman's right hand as opposed to his left hand, and also the slowness of movement was evident in his facial expression, which was very what we call masked, and you may be familiar with that change in facial expression that affects the ability of people with Parkinsonism to communicate their emotions. The third video will show you a lady who has very significant postural instability or loss of balance, and she is you'll see that when she's standing upright and not supported by anybody, she even spontaneously falls over, even when not pushed.
Now you can turn to the left towards your husband. Okay, and now leave your husband and try to stand.
Stand up.
Get up.
Stand up.
Okay. And now
Okay. So, well, progressive supranuclear palsy and multiple system atrophy both qualify as disorders of Parkinsonism. Often the term atypical Parkinsonism is applied to these conditions, or they also come under the umbrella of what is called Parkinson plus syndromes. And these are terms that are generically applied to neurodegenerative diseases that are not Parkinson's disease. Parkinson's disease is considered the prototypical, usual Parkinsonism, and these are different. And so they're called atypical. When I say neurodegenerative, I'm talking about a disease that causes a progressive loss of neuronal health or health of brain cells, and the key term there being progressive. So how do then multiple system atrophy and PSP differ from each other? They both have a core feature of Parkinsonism, but beyond that, there are some symptoms in common, but many that are different, and they involve this reflects the involvement of different brain areas. You can see in the second picture from the left-hand side, you can see that there are some core areas at the base of the brain or in the center of the brain that are affected in MSA. The blue areas are unaffected, and the pink and red are affected areas. And these the dark red spots are those areas that account for the motor features of the disease, or the movement features. So that's where what areas are responsible for the Parkinsonism. And then beyond that, we start to involve areas that account for other symptoms. So at the far right-hand side of the slide, you can see a picture that highlights the areas in the base of the brain, or the brain stem, that are responsible for areas that maintain our normal physiological functions, like stability of blood pressure and stability of body temperature. And these areas are significantly affected in multiple system atrophy. In contrast, in progressive supranuclear palsy, we have significant involvement of the upper parts of the brain, the cortex, there across the top, which accounts for the cognitive, or the memory and thinking functions that are impaired in PSP, as well as the behavioral changes that we see in PSP. And this is then in addition to degeneration at the sort of the base and the center of the brain that you see, that's common to the two disorders. The two disorders also differ at the microscopic level in terms of what protein is accumulating. And so there is a different biological process that's happening in the two diseases. And in multiple system atrophy, we have accumulation of a protein called alpha-synuclein. And in PSP, there's accumulation of a protein called tau. And so there's really fundamental biological differences between these two conditions, despite their common clinical features. So I'd like to turn now to the signs and symptoms of the disorders. And as I mentioned already, there are features in common. Fundamentally Parkinsonism, but also swallowing difficulty, speech impairment, and an early loss of balance are common features between the two. Beyond that, they begin to differ. And so this list will show you some of those differences, where in PSP we have a prominent loss of eye movement ability. And I should give the caveat that there is hardly any symptom in either of these disorders that is universal across all people. They are very heterogeneous if you look from person to person. So you may not identify with all of these symptoms, but I'm sure you will with some of them. But loss of eye movements is a common symptom in PSP, and actually characteristic of the disorder. And this is particularly a loss of downward eye movement, but eventually in all directions. There's also prominent cognitive impairment and impulsive behaviors in many people with PSP. In contrast, multiple system atrophy tends to have a preservation of cognitive function, but more impairment of those sort of fundamental physiological processes that maintain stability of our body temperature and body blood pressure. So we have low blood pressure when going from a sitting to a standing position, difficulties with urine control. Men may notice early impotence, and there is a characteristic breathing disorder that happens in multiple system atrophy called stridor, and I will explain more about what that looks like in subsequent slides. Multiple system atrophy is also itself a somewhat umbrella term for different subtypes of neurodegeneration. And there is a subtype of multiple system atrophy that has prominent ataxia or cerebellar coordination difficulty, and may have actually very little Parkinsonism, at least in the early stages. And so this is yet a different subtype that has other kinds of coordination difficulties. Okay, so now I'm going to turn to talking about individual symptoms that we see, and talk about our current therapeutic approaches to them. So first of all, balance difficulty. This is almost universal across both of the disorders. And in Parkinson's, in PSP in particular, it is made more dangerous by impulsivity. So people who know individuals or who have PSP may identify with the situation where, you know, all of a sudden the idea pops in, I need to grab something from across the room. And so they'll up out of the chair and start to get across the room and fall over. that impulsive thought is, can't be inhibited by the knowledge that they have, very severe loss of balance and can't wait until somebody comes to help them across the room. So this makes for a very challenging caregiver situation in PSP, where people may need really constant supervision in order to stop these impulses to get up and go. And to some extent, the cognitive issues in PSP will also impair the insight into their own loss of balance. So these overriding cognitive and behavioral issues are less of a feature in multiple system atrophy, but nonetheless, the balance difficulty can be very disabling. Unfortunately, medications like levodopa are poorly effective to manage balance difficulty in these conditions, and our management consists of mainly physical therapies and occupational therapies to maintain safety and also to optimize mobility. So we often will engage physical therapists and occupational therapists to help us in this regard, and those can be accessed privately through community physiotherapy clinics. They are self-referred in that you don't need a physician referral to go to physio or occupational therapy, although it may be helpful for the doctor to recommend somebody who has particular knowledge in these disorders. I will often refer patients for physical and occupational therapy through CCAC or the home care program. And it's useful to have, say, an occupational therapist come to the home in order to see you or the person you care for in their own home setting and make recommendations for modifications to adapt to the balance difficulty and the mobility difficulties that are occurring. However, it's not a good solution for ongoing long-term physiotherapy because that will be rather short-lived in terms of the intervention, and they will only provide a few visits. But it can be, it's a very useful feature for somebody to see the person in their own setting. Physical protection may be necessary, particularly in PSP, where people lack the insight to stay seated until they're helped. And so I have patients who wear hip protectors and knee protectors in order to help themselves avoid injury with these problems. I even had one patient who was a member of a curling club, and he came to me one day. He had PSP, and he was very happy with his headband that has padding all around it, and is used by curling players to prevent injury if they hit their head on the ice. And so that was a solution that he had come to, which I thought was quite novel. Ultimately, or eventually, walkers and wheelchairs are important aids for people with these disorders, and they are often seen as in a negative light by people and care partners, as being markers of progression of disease, but they are really important facilitators of mobility, and particularly walkers, which can be used on an as-needed basis in order to improve the distance that somebody can walk, and also the safety of walking is important. However, walkers are certainly not a fail-safe method for ensuring safety, because people can still fall to the side and backwards, and so may still need that accompaniment, but at least it encourages the active walking and weight bearing and allowing somebody to get around in a more safe manner. Swallowing difficulties are also very common across the two disorders. I've put here a line that says most dangerous symptom, but I suppose that's arguable. But I've put it there because it can result in pneumonias, and it can result in choking episodes that can actually be fatal. And in particular, it's a symptom that is usually under-recognized. It's due to loss of coordination or a slowness of the swallowing muscles. And when food and liquid and even saliva go down, they are entering the airway instead of being solely directed down the swallowing tube. And when particles enter the airway, they can become little focuses for, or foci for starting infection, which can lead to pneumonia. And so even those smaller particles and droplets of saliva can be dangerous. The symptoms of swallowing difficulty in these disorders range from food sticking in the back of the throat to things taking several swallows to go down, to coughing after swallowing food or liquids. And the latter is a late symptom. And speech language pathologists like to try to catch people before they're actually coughing on things, because that is a sign of frank aspiration or things going down the breathing tube. So we will usually ask for a speech language pathology or SLP consultation in order to assess swallowing if we're suspicious that swallowing is an issue. And the management strategies that I have heard from my SLP colleagues include taking small bites and sips in order to make any swallow less risky. Tucking the head when swallowing in, so the chin towards the chest, can help to improve the control of the throat over the swallowing. Avoidance of mixed textures is important, and there I mean by mixed textures you could think of a bowl of soup with solid little vegetable chunks floating in it. That's a mixed texture that is difficult for the swallowing muscles to control. Thickening of liquids is a mainstay strategy for managing swallowing difficulty, and thickeners can be purchased at drugstores and help to control the liquid as it goes down. The moistening of solid foods is important in order to avoid little crumbs of things going down the airways, because then the food sticks together better and is more easily controlled as well. I've put here 3 question marks after gastric feeding tube, because it's a question that I'm often asked in the later stages of these disorders, whether or not it's time for a feeding tube. And the question usually comes from a caregiver who is worried that the person is not getting enough nutrition because feeding is either very, very slow, or the person just holds the food in their mouth, or they're coughing with every meal. And it's certainly not an easy, there's no easy answer, and there's no right answer to whether or not a feeding tube is appropriate. And I usually talk then to the patient themselves, and it's important that this conversation happen before the person loses the ability to communicate their answers and or to understand what we're asking. I ask the person themselves, if eventually you were unable to eat by mouth, would you want a feeding tube placed? And then we talk about the pros and the cons. And so that's a very important thing to know from the patient themselves. And often the patient will say no, they wouldn't want that. But I do have some patients who've said yes, that seems appropriate to them. And the usual positive benefit of a feeding tube is that when a tube is placed through the abdominal wall and directly into the stomach, then nutrition can be dripped through the tube several times a day, so that they get enough calories and vitamins and liquid to keep them well nourished. And that is a great psychological relief to a caregiver, to know that the person is getting enough food and liquid to sustain them well physically. It's important to know that this does not completely eliminate the risk of pneumonias and food or the feed that's delivered through the tube going into the lungs, and certainly doesn't change the risk of saliva going into the lungs. And so pneumonias can still happen despite it, but it does reduce the risk, and certainly takes away the risk of choking episodes. On the other hand, there are certainly aspects to a feeding tube that sustain a person that need to be considered, and they're really not quantifiable. And a person it may not be in keeping with a person's wishes to want that kind of invasive intervention or invasive therapy. So it really does need to be addressed one-on-one with the patient, and considering the family together. I'm often asked if putting in a feeding tube will prolong life, and the answer is that it can. Certainly if nutrition is a limiting factor for health, if the person isn't able to keep up their hydration, then a feeding tube will prolong life related to preventing dehydration. But there are many other causes of death in these disorders that the feeding tube will not necessarily affect. So the answer to that is sort of, it depends. Okay. Speech impairment is very common also in each of the conditions, and probably tends to be somewhat more impaired in PSP. There can be slurring of speech, but also changes in the tone of voice, and the voice may become soft even to the point of being inaudible. For this, again, medications are not very helpful, and we rely on other strategies like speech therapy. So we have speech therapists here that understand the disorders of Parkinsonism and how they affect speech, that can improve vocal volume and clarity. Speech therapy is expensive, and some of my patients have instead used a self-guided exercise program that's available, that can be ordered online, and I've written the name there so that you can Google it. I've had positive feedback about that, but it requires a special patient who is highly motivated and will practice. So it requires good cognitive skills and motivation to do this. If speech is more severely affected, then people require communication aids such as tablets where they can point to commands that they want to express, or have a picture book that represents different things that they need to communicate. For that purpose, we have communication clinics at hospital that are hospital-based generally, that can provide this kind of service. And I will refer my patients usually to Bridgepoint's communication clinic for this purpose, but other ones certainly are around. Next, I'll talk about the behavior changes that we see, particularly in PSP. And these behavior changes can include inappropriate laughter or crying. And when I say inappropriate, I mean that they're not associated with any appropriate emotional context of sadness or mirth. We do have medications that can address these, and so talking to the doctor about the possibility of treating them if they become a real disruptive behavior is the way to go. I already talked also about the impulsivity that we see in PSP, where people have difficulties restraining those impulses to reach out for things or to get up out of the chair, and that's very common and difficult to manage, and may require a constant sitter for people with PSP. The impaired eye movements are characteristic of PSP, and this is not a symptom of multiple system atrophy. But I will address it briefly because it's very important in PSP. We see a progressive, particularly downward loss of eye movement. So if someone can't look down, then they'll have difficulty responding to or directing their attention to anything that is below their eye level. So for example, when they're presented with a meal, seeing the food on the plate is an issue, and they may have difficulty reaching out for that food. And the strategy of just raising that up, for example, on a shoebox or some other platform that brings the food more to their eye level can be very, very helpful. They may also have difficulty walking downstairs because of the difficulty moving their eyes down. They can also, if the eyes are not coordinated together, they will often complain of double vision. The latter can be improved. Well, it can be cured by covering one eye, and so that is a fail-safe method of addressing double vision. But barring that, there also can be prisms applied to the lens of glasses that can help to pull the vision together so that only one image is seen, and that would be a neuro-ophthalmologist who would apply that, or some ophthalmologists will as well. So that you can inquire with the neurologist about whether or not that might be appropriate. I wanted to mention that we often forget when we're interacting with people with PSP to make sure that their eyes are directed towards what we want them to see. And whether this is something that you want to show a patient with PSP, or me talking to a patient with PSP, if their neck is held back and their eyes are directed towards the ceiling, we're really not doing them any service by trying to say, come, look at this, because they can't change where their eyes are and where their head is directed. So we need to help them with that by putting the object then up high for them, making sure that we're facilitating them seeing what we want them to see. I already mentioned to some extent the cognitive impairment and behavioral symptoms that we see in PSP. I mentioned the impulsivity and the difficulties with judgment, but we can also see other kinds of behaviors. A repetitive moaning sound may be produced by people with PSP, or they may have very significant agitation. And once again, we really lack medications that effectively address these, and usually rely on behavioral strategies to try to help them. It's important to minimize multitasking. So if we're asking them a question, make sure you ask only one thing at a time and don't ask double-barreled questions. Emphasizing routine, but also providing activities that can occupy the person are important. And day programs in the community can be a very important aspect of life that not only provides stimulation for the person with PSP, but also provides a break for the caregiver, and that is crucial in the course of PSP. I mentioned already that the person may need a personal support worker for constant attendance, and to some extent, home care or CCAC can provide hours in the week for this, but may need to be supplemented with privately paid caregivers, which I realize is not within everybody's reach, but if it can be, it's a good investment and can be very helpful. Now I'd like to turn now to some of the unique symptoms of multiple system atrophy, and the breathing difficulties that we can see with multiple system atrophy are really quite unique. They consist of an involuntary closure of the vocal cords, and this leads to, when air is brought in to the lungs and goes through the vocal cords, it's like whistling through the vocal cords. So a high-pitched sound can be seen, and this occurs predominantly in sleep. So it may not be noticed by the person themselves, but only by their caregiver. And it is scary to think that this can lead to sudden death if the vocal cords close completely. So if this sound is heard, it's important to mention it to the physician. And we would do a sleep study where overnight a person is monitored to see whether or not that actually is occurring. And then there are various management strategies including, the mainstay of therapy is positive airway pressure. So you've probably heard of CPAP machines that people use for sleep apnea. So similar kinds of devices can be used to keep the vocal cords open. And sometimes the question comes up if that is insufficient or impractical or not tolerated, whether or not a tracheostomy is needed, that is putting a little hole in the front of the throat below the vocal cords in order to bypass the obstruction. And while it does bypass the obstruction and definitely would relieve this stridor, there still have been recorded instances of death, even in the presence of a tracheostomy. And it's thought that those instances may have resulted from central control breathing difficulties. Again, the control of those fundamental physiological processes is disrupted and may be a cause of death in multiple system atrophy. Bladder control is a significant problem in many people with MSA, and it has two sides to it. One is urinary incontinence, where loss of control of the urine results in accidents, and on the flip side, difficulties emptying the bladder or urinary retention. When urinary incontinence is a problem, this can be often effectively managed with timed trips to the bathroom, where you try to keep the bladder empty regardless of whether or not you feel the need to go. And protective garments are also a mainstay, obviously. But there are medications in addition that can help with this issue. So we have at our disposal a number of different bladder relaxant medications that can help to reduce urinary incontinence. On the other hand, if urinary retention is a concomitant problem, then the relaxants can worsen the retention. So that's a difficult situation. Botulinum toxin injections into the bladder wall have been a recent addition to our treatments for urinary incontinence, and can be very effective. Those would be strategies that would be managed by a urologist, and I'll often consult my urology colleagues for that purpose. So urinary retention is a difficult problem because when urine is held in the bladder for too long, it can become infected. And so if urinary infections are a result or happening frequently, then it may be necessary to catheterize the bladder in order to empty that, and that can be done intermittently, or it can be done permanently. And these kinds of interventions would be undertaken with the advice of a urologist. All right, so now I want to turn to talking about some recent research progress in these two disorders. I think we're at an exciting time where we're really understanding more about the underlying disease process, and we can hopefully make some very significant progress in the next few years to more specific disease therapies. Now, understanding what research is going on, I think, has two purposes. One is it's definitely a source of hope for people with PSP and MSA. It's also potentially a source of empowerment in the participation in research, if it's at all possible for you, can be a very satisfying experience that can provide meaning also to these days. And there's no question that we absolutely need research progress in these diseases, and it's really important that patients and care partners participate, because without being able to conduct proper studies on medications that are proposed to be effective on the people who actually have the disease, we can't understand whether or not they are effective. So the information that I'll share with you now, I have obtained through a website called clinicaltrials.gov, and I'll show you that URL at the end, so you don't have to write it down now. But that is a source of up-to-date information about ongoing clinical trials, with information about inclusion criteria, the reason for this, the rationale for the study, where it's going on, so that if you're at all interested in participation, then this would be a good place to go. So one of the most exciting areas of new research in PSP is the development of anti-tau antibodies. These are antibodies directed against the protein that accumulates in PSP. And these two antibodies that are being developed by different companies, they are aiming to slow the disease process and prevent the spread of the abnormal protein, or slow it down. And currently these are entering clinical trials in humans. And so I think within the next couple of years, we will know much more about their efficacy. These studies are occurring in North America, and here in Toronto, we are participating in one of them. I put this study here looking at the quality of life of the patient, and also the burden on the caregiver imposed by PSP, as a reminder to that how much we need to know about the determinants of health of caregivers in these disorders, and we need to understand how best to support caregivers in these conditions. And so I was happy to see that this study of 160 participants is happening in France, and hopefully within the next couple of years we will have more information about how to support caregivers. There is a need to diagnose these conditions earlier, and neuroimaging hopefully will play a big role in this. And particularly in PSP, we're learning how to image the accumulation of the tau protein. And there are now several ongoing studies using specific molecules that can bind to that protein, and we can visualize that on functional neuroimaging. And hopefully using that strategy, we'll be able to identify these disorders and distinguish them from Parkinson's disease and other conditions earlier. So stay tuned for better diagnostic methods, because these will be critical to intervening with disease-modifying agents earlier in the condition, and thus making optimal use of the disease-modifying agents. Several other medication-related studies going on in PSP for cognition. That is rivastigmine, which is borrowed from the Alzheimer's and Parkinson's disease fields. The second study there is of an anti-inflammatory agent, which is being studied for disease modification, and is currently in the early stages. Turning to MSA, there is similarly interesting research going on to strive for disease modification. The agent inosine is a molecule that raises uric acid levels. If you raise it too high, you'll give a person gout, but if you raise it just a little bit, it can be well tolerated. And the inosine is currently under study for disease modification in Parkinson's disease in a study of several hundred people, and that will come out, the results of that will come out this coming year. And borrowing from that, it is being studied as well in 80 participants in a study in Korea. And so if that works, then I think we'll see that expand internationally. Similarly, sirolimus is another agent that's being studied for disease modification, and this one is in North America, and is a promising agent that hopefully will be able to enhance the clearance of the protein alpha-synuclein that accumulates in multiple system atrophy. This is in the early stages. Again, just as the first study of significant size in humans ongoing right now. Finally, my final slide before the end, I'll just mention that there is interest in stem cells. Almost every neurodegenerative diseases has there's the question whether or not stem cells can be useful, and I would say the answer right now is we don't know, but there is stem cell research being conducted in MSA, again in Korea, and this is a study of an agent that is taken from the person's own blood, and the stem cells then are derived from that bone marrow. I'm sorry, not taken from blood, taken from the bone marrow. The stem cells are processed and then injected into the person's own carotid artery. And I don't know if that's going to turn out to be a viable therapy at all, but it is an avenue that's being investigated. Okay, so this is the final slide, and I'll just highlight some take-home messages. Again, reminding you that, well, Parkinsonism is the category of these disorders. They are much more than that, and they're complex disorders of not only motor symptoms, but non-motor symptoms as well. And I'm sure I'm talking to the converted when I say that, but there is promising research. I think we're making exciting progress, and hopefully over the next 5 years or so, we will get far in terms of more specific therapies. And if you want to keep track of what's going on, or hopefully participate if it's all feasible, then clinicaltrials.gov, as listed there, is a authoritative website where you can get the relevant information. So I'm going to stop there, and thank you very much for your attention, and I'm happy to take questions over the next few minutes.
Thank you, Dr. Maris, for a really eye-opening journey through the atypical Parkinsonisms. Our audience will have many questions for you. So let me now provide them with some brief instructions on how they can ask those questions. And before we begin the question and answer portion of our session, we want to remind everyone to please take a few minutes before you log off to provide us with your feedback by completing a short survey. Your input is very important and will help identify topics of interest for future webinars, as well as help us better meet your needs. We want to remind you that you can ask the questions by selecting the To Admin button at the bottom right of your screen. And we'll now open the forum for questions. So our first question, Dr. Maris, is do you recommend speech-language therapy in the early stages to help delay communication issues? Or as you mentioned, perhaps prevent future swallowing issues?
Mm-hmm. I must say we've not used speech therapy or speech-language pathology swallowing assessments in a preventive sense, although I think, so for speech therapy, I think it really is probably best applied when difficulties are starting to emerge, not earlier than that, because it would be difficult to have anything really to work on. On the other hand, swallowing assessments may be a bit different in that swallowing difficulties can certainly be silent, and earlier rather than later SLP referral for a swallowing assessment, if the resources available could be useful and may uncover things that you don't even know are there.
Thank you. And having said that, do you also recommend physiotherapy? At what stage would you recommend physiotherapy?
So I think that there is more and more evidence in the context, not necessarily of PSP and MSA specifically, but just in disorders of Parkinsonism and really all neurodegenerative disorders that involve mobility issues, that physical therapy is probably as an important parallel to medication. And when I say physical therapy in this instance, I'm talking about learning to exercise to your abilities, practicing balance so that you have as much reserve as possible in order to stave off the effects of the disease. So physical therapists can be a great resource for exercise programs, and they don't necessarily have to be just relegated to, prescribing walkers and dealing with balance difficulties or preventing falls. So I think there is a role for early physical therapy, absolutely, if it's within your means. And I think that there's also more and more evidence that physical activity, is also cognitively helpful. It helps preserve not only physical health, but also cognitive health. One thing that my patients with Parkinson's disease have benefited from is knowing that a physical trainer is cheaper than a physiotherapist. And so that if it's impossible, for ongoing physiotherapy, from a financial point of view, then engaging a physical trainer at a local gym, especially in the early stages, can be a very cost-effective option.
Oh, that's a great suggestion. There's been some talk about the use of antidepressants as well, that it may possibly help some individuals. What can you tell us about that?
So depression is a very common non-motor symptom in these conditions, and it not only itself impairs quality of life, but it also, people who are depressed have an amplification of all of the other symptoms of their disease. So it's important to address this wherever possible. I think that depression is, if I try and extrapolate from what we know in Parkinson's disease, where there have been a number of clinical trials about antidepressants, it seems that the condition responds to the usual antidepressants that are used in the absence of Parkinsonism. And I think the same probably applies to PSP and MSA in my experience. But I must admit that we don't have really robust research to tell us that. Often also, antidepressants aren't necessarily the answer for all people who have depression in these disorders. It may be reactive, situational, sort of an adjustment disorder, in somebody who is having difficulties with a very dramatic changes in their lives. And in that kind of setting, I usually will refer my patients to a neuropsychiatrist who understands both the neurology as well as the psychiatry, and they can decide whether or not antidepressants are the best way to go, or as opposed to some kind of counseling or more psychotherapeutic approach.
Okay, we've got lots of questions, and I want to make sure we get to all of them. So can you share the results of your PSP study on environmental factors? One of our participants is asking.
Right. Well, thank you for asking. So we have identified some chemical exposures that appear to be related to higher PSP risk. These are, exposures that not necessarily all of us have been exposed to, nor can we identify a specific event in all of our PSP patients that indicate exposure to those chemicals. And so it seems to be a risk factor, but not the answer in everybody. We studied also some genetic risk factors in that study, and identified again some variants that increase risk for PSP. We studied whether or not anti-inflammatory use correlates with PSP age at onset, and did not find a relationship there. So results, I think, which indicate to us that there's probably no single cause for PSP, but that there are environmental and genetic risk factors that come to play that are, combine in any one individual to determine whether or not they get the disorder. So I think it's a complex disorder in terms of cause.
So it could be a combination between nature and nurture.
Exactly.
Yeah. So also we have another question. Are MSA and PSP mutually exclusive?
Oh, I don't see any reason why they should be mutually exclusive. They are different conditions, but there's nothing about getting PSP that protects somebody from MSA. They're rare enough that I've never heard of the combination in a single individual. But that's probably related to statistics and not to any protective factor.
Okay. Just a couple of more questions. Now, the impulsive behaviors we see in PSP, are they related to the levels of dopamine?
That's an interesting question. I don't think they are. The impulsivity is probably related to the degeneration of the frontal lobe areas of the brain in PSP. And dopamine is more responsible for so I should say lack of dopamine is responsible for the motor features of the condition, but these behavioral features are probably related to other neurotransmitters that are lost in the course of degeneration in the frontal lobe areas of the brain.
Okay. And in terms of the progression, we know with Parkinson's disease, for example, that in the early stages, it's unilateral, and then it becomes bilateral in terms of the motor symptoms. What can you tell us about the progression of PSP or MSA?
So MSA and PSP are more commonly symmetrical on both sides of the body at the beginning than Parkinson's disease is. However, that's not universal. I have had lots of patients with both disorders that present on one side and then progress to having both sides involved. If they do present on one side, it usually more quickly becomes two-sided than in Parkinson's disease.
Okay. Well, I think we're going to wrap things up. That's it for our questions. I'm just going to ask the participants not to log off yet. Parkinson Canada values your feedback, so we remind you again to please complete the post-webinar survey. The link is in blue at the top of the chat box. You'll see it there. On behalf of Parkinson Canada, I want to thank you, Dr. Connie Maris, and our event sponsor, Synovian, as well as everyone online for participating in today's webinar. For more information on the atypical Parkinsonisms or to access a recording of this webinar, please visit our website at www.parkinson.ca. And if you have any further questions regarding today's session, feel free to contact us by email at info@parkinson.ca or call us toll-free at 1-800-565-3000. As we sign off, we at Parkinson Canada would like to wish all of you a wonderful day. Thank you.